starting part 3 of Unit 3. Objective 36, discuss the incidence and management of multiple gestation during labor and birth. Multiple gestation has steadily increased since 1973 because of the use of assistive technology like the use of in vitro fertilization and using fertility enhancing drugs such as Clomid. And there's also been an increasing age of women giving birth. And when that happens, they do use this assisted technology or fertility altering drugs in order to increase their chances of conceiving. Dizygotic twins are also known as fraternal twins. They come from two separate eggs and have two separate sperm that fertilize each egg. They may or may not be the same gender. They're basically like brother and sister. Monozygotic twins are identical twins. They're one egg and one sperm. They are always the same gender. Monozygotic twins, again, are from one egg and one sperm that during the blastocyst formation separate and form two babies that have the exact same genetic material. Conjoined twins are a type of monozygotic twins. They basically have an incomplete embryonic division at 13 to 15 days post-conception. And this is in figure 18.4 on page 187. Multifetal pregnancies have an increased risk for adverse outcomes. There is an increased strain on the maternal cardiovascular system, and it's not uncommon for moms with multifetal pregnancies to go into some form of congestive heart failure following the delivery of their babies. Preterm labor and preterm birth is also common because the uterus is usually only able to stretch to a 9-pound capacity for a baby, a liter of amniotic fluid, and about 2 pounds of placenta. With multifetal pregnancies, that capacity is reached at an earlier gestational age. Prenatal care for multiple fetal pregnancy. The visits are scheduled every 2 weeks in the second trimester and weekly in the third trimester. Ultrasounds are usually started about 20 weeks gestation, and then they occur every 3 to 4 weeks to monitor for fetal growth and also the amount of amniotic fluid surrounding each baby. The recommended weight gain for somebody who has a multifetal pregnancy is between 35 and 45 pounds for a twin gestation, and that can increase for the more embryos that are with the pregnancy. There's also an increased risk for preeclampsia and eclampsia associated with multifetal pregnancies. Objective 29 says examine physiological changes that occur in various body systems during pregnancy. This is in table 10.2 on page 213. Presumptive signs of pregnancy are signs of pregnancy that the mother states. They are subjective signs of pregnancy. These include amenorrhea, nausea and vomiting, breast changes, fatigue, urinary frequency, and quickening. There are other things that can cause these signs and symptoms besides pregnancy in a woman's body. Probable signs of pregnancy are objective signs of pregnancy. They include Chadwick sign, Goodell sign, Hager sign, uterine and abdominal growth, colosma, which is the mask of pregnancy, linea nigra, which is the linear line on the abdomen, ballottement, Braxton Hicks contractions, and a positive HCG pregnancy test. Positive signs of pregnancy are objective signs that can only result from pregnancy. So there's no ifs, ands, or buts that this person is pregnant. This includes auscultation of the fetal heartbeat, ultrasound of the fetus, observation and palpitation of fetal movement by the examiner are the positive signs of pregnancy. NCLEX style question, which of the following should the nurse recognize as a positive sign of pregnancy? Obviously the answer is B, hearing the fetal heartbeat. When we talk about pregnancy, we need to talk about gravida and para. Gravida is the number of pregnancy regardless of gestation. So if she is pregnant at all, her gravida increases by 1. Para is the number of offsprings born after 20 weeks gestation, whether these offsprings are born alive or not. T stands for the number of full-term infants, and these are infants born between 38 weeks gestation and 42 weeks gestation. The second P, is the number of preterm infants. These are infants born between 20 weeks gestation and before 38 weeks gestation. A is the number of pregnancies either spontaneously or electively aborted prior to 20 weeks gestation, which is the age of viability. And L is the number of living children now. Based on these examples and these scenarios, you should be able to calculate GPTPAL. The one thing I would tell you is a twin pregnancy counts as one gravida because it's one pregnancy, but when the twins are born, then the para would increase by 2 because of the fact there are 2 offspring at that time. A client is pregnant for the first time, she is termed, and it is called a prima gravida. Calculation of due date. Calculation of due date uses the pregnancy wheel, which you can see right through here, and that's based on that a average pregnancy is 280 days. EDD is estimated date of estimated due date, and EDC is estimated date of confinement. They are basically the same thing. It is the patient's due date. We use the last menstrual period to calculate due dates if we're going to use either the pregnancy wheel or Nagel's rule. Nagel's rule states you would subtract 3 months and add 7 days and correct the year as needed. You need to pay attention to how many days in the month each month has. So October has 31 days. April only has 30 days. And so it's important to know that as you calculate using Nagel's rule. And again, in the last one, since she gets pregnant on her first day of her last menstrual period is January 1st, 2013, that baby will still be born in that year of 2013. Pregnancy tests measure for HCG, human chorionic gonadotropin. This is on page 211 in your book. There are a variety of over-the-counter tests available. Teaching for self-management, if somebody has missed their period, they need to take a pregnancy test. Even if it is negative, they should wait 1 more week. If they still do not have their period, they should take another pregnancy test. If it is still negative at that time, they need to contact their healthcare provider. HCG levels can be detected as early as 7 days after conception. Basically, what needs to happen is that blastocyst needs to start to go through implantation. And once implantation is occurring, the patient's HCG levels will rise. Lab values for pregnant women often differ from normal lab values for adult females, and I would encourage you to look at the highlights from page first based on these lab values. Typical laboratory tests that are done while a patient is pregnant include hemoglobin, hematocrit, white blood cell, and differential. If there's a risk for sickle cell anemia or thalassemia, they may do a hemoglobin electrophoresis. We look at their blood type, Rh, and if they have any antibodies. They will do a rubella titer, a tuberculin screening, skin testing, a urinalysis with potential culture. They will look at renal function tests, B1, creatinine, electrolytes, creatinine clearance, and total protein excretion. They will collect a Pap smear for the presence of HPV. There will be swabs for gonorrhea, chlamydia, potentially HPV, and also beta strep. We will do a syphilis screen using an RPR or VDRL. They'll do an HIV antibody screen and a hepatitis B surface antigen screen, and also looking for toxoplasmosis. The patient will have a 1-hour glucose tolerance test, and if that is abnormal, they will have to go into a 3-hour glucose tolerance test. Other things that may be ordered include cardiac evaluation, ECG, chest X-ray film, and potentially an echocardiogram if there's any cardiac disease or history of hypertension in the family.